So can I now introduce Dr. Paul Rice, who's the Head of Technology Strategy North in the Ops and Informations Directorate. It's quite a long one, that. Do you want to say what you want to say about you? You've obviously...
and just...
He's the money man.
No, he used to be the money man. He's not the money man anymore. So.
Well, welcome, Paul.
Thank you. Sorry. Yeah, Declan's the money man. Thanks, Declan. They'll come to you in the break and ask you for money. That would be very helpful. Morning, folks. I'm Paul Wright. Amanda's a real doctor. I'm a PhD doctor, so if anybody collapses in the room, look for the real doctors around you. For God's sake, don't ask me to respond. We can have a moral debate about whether you're alive or dead. That's not much use to you. What I want to cover in the next half a dozen slides is just where we are in this life cycle of a couple of programs. One of the ones in the middle, the LACRA discussion, terrible acronym. It's an interesting one because of where we are in the time cycle in relation to that, but I wanted to pick that up in the course of this, and then finish with something completely different in terms of an image that I picked up earlier in the week, which I just think again is pertinent. I had one of those stinking journeys coming across the M60, but one of the benefits of listening on the radio is that almost every day you appreciate to some extent or other the digital impact that we're dealing with. Whether it's the conversation yesterday morning, which if anybody was driving to work, practically in tears, Rachel Bland, who's one of the 5 live presenters, who's a contributor to a fantastic podcast about me, and the Big C, I think that's what it's called, reflecting on the challenge she now has, having had invasive surgery and chemotherapy, with now having gone back and that cancer reappearing. But a whole conversation really about personalisation and about if we don't get to a point of understanding diseases at that individual level, which is all about understanding the rich data points that we can access in our system, we will not be able to respond to and meet the care and needs that she has. The one this morning, in a different context, was House of Fraser falling down around our ears, because in practical terms, they've got lots of big buildings and people aren't shopping there anymore. So again, to Amanda's point at the outset about just changing the whole model of care, digital is doing that in every other aspect, so it's going to do it in the context of healthcare, whether we like it or not. But if we embrace it, and again, I had 10 minutes last night, saw a bit of television, fantastic programme about changing your carbohydrate intake. But in the middle of that, the 12 participants who were volunteers using social media over the fortnight to boost one another, to share recipes, to show pictures of what they were eating for their dinner. So again, you cannot move at the minute without the impact of digital more broadly, and then the touch points between digital and healthcare and our lived experience. Again, these are corporate slides, but effectively 4 critical challenges. My previous world predominantly about improving providers' digital maturity, and I would still focus on the necessity to, at the point of care, be in a situation where when you're receiving that care, you can be confident that it's highest quality, it's informed by the best current knowledge, and that in relation to access things like decision support, those clinicians and professionals have got access to the best of that. But again, relevant to this conversation, that's not just providers limited to the healthcare sector. We're talking about something which is every opportunity, every venue of care, every contact of care. Connect and integrate, which I'll focus on in a minute, better use of data and information, and then ultimately the opportunity to just reshape the whole programme of services for the public. And to Nick's point earlier on, I think we are inevitably in a direction of travel which says whether we change the acronyms again and again, the experience is one that has to be about the health and social care wrapper, not the distinction between those two things. Support and next steps, what's it about? And this is where the LACRA programme steps in as well. But effectively, for you as an individual, a lifelong longitudinal care record that's comprehensive and that is accessible for the coordination of that care. The ability to stand behind that and understand what's it really telling us about how people access services, what their experiences of services are, how they don't access services and where the gaps in those services are. What is it that is faced down the person who's profoundly standing on that bridge contemplating ending their life that meant the service offer that we thought was there for them wasn't adequate? And how do we respond to that differently? And how do we do that that's not about guessing, but it's actually about understanding? And then back to my Rachel Bland example, that broader point about research and unlocking the insights that those ones and noughts will provide to really get us to a level of individualised care and personalised medicine going forward. and again, just to reiterate, and this is the right environment and the right audience to say this, but fundamentally care not limited by organisational boundaries. That's that journey. That's not going to happen overnight. But as long as we're set on that as the end point, then I think that's a very rich place to be heading for. Local health and care records, again, standing in the LPRES environment, standing in the environment where there are other shared care record examples, it seems a bit rich to say they are not new. They are not new. That programme has surfaced at least 60 examples of shared care record instances in play. What they haven't been historically is necessarily scalable, and what they haven't been is being used for a whole of the rich variety of ways in which they can. Fingers crossed, the next couple of weeks we get through the LACRA process and there is more immediate investment coming into this community and into the North more broadly to support that. But again, the interesting thing seems to have been that regardless of whether that resource is available in the next 12 or 18 months from the centre, the commitment on the ground to make these proposals actually fly is the same across the whole of the North. Again, I'll pick that up in a moment. Again, reiterate, depersonalised data, an understanding of what can be done in a local context. The units of 40,000, 60,000, the people that relate to services on a daily basis, and the aggregates that can be done brought up from that. Coherence and consistency, so you can do that scalability, and the thing that you capture in one environment and another environment are able to be richly combined. And then wherever that comes from, wherever that insight comes from, that particularly given the demographic change, particularly given our necessity to move more services out of the acute environment, that you're not just capturing all that insight from contact in acute care, but you're capturing that insight from every community touch point, every society touch point that an individual has. Fundamentals, again, to make this work, public and professional trust. We're not in control of all of that environment. I'm absolutely certain that, again, anybody, TSB yesterday, the anxieties around digital that will be precipitated by that, Cambridge Analytica the day before, I mean, to that culture, to the Roy Lilly one, that coral reef is going to have to work in an environment where that water is being warmed, where that plastic's flowing around it, not always from healthcare. It's from general society concerns and anxieties about these things that we're going to have to respond to. And that's where that local leadership and commitment to the delivery will become really important, because it seems to me unequivocally that messages from the centre in this context are marginally useful. Commitment and passion and understanding at a local level conveyed by someone who you trust, much more likely to get us to a position where patients and service users are comfortable with what that data says and how that data could ultimately be applied and used. Again, it's interesting, Nick wasn't a plant, but to again reiterate the point that this direction of travel is an inclusive one, and that it's an inclusive one to understand social care's insights and perspectives in this context as much as it is health ones. I'm NHS England, NHS, the words that appear to capture a particular view of the world. I think increasingly with ICSs and our other three-letter acronyms are actually still absolutely talking about place and people's lived experience in that context. And the Local Government Association have been and are as instrumental in the decision-making process around these LACRA investments as health is. Again, I've probably made these points as I've gone along. Precise interventions, understanding what we can do, being a platform for research, and that's not, that's a wider economy principle and point as well. That's my son's doing his GCSE maths this morning, I think. It was English history, maths this morning. His orientation feels to me to be towards life sciences and information technology. If 16-year-olds express any preferences about anything except Fortnite, I want to be in a position where I can see, and we can all see, an economy developing and booming for him to apply those skills going forward around that life sciences agenda. The last thing I wanted to say that in the context of the process around LACRAs is I genuinely think it has demonstrated that you can get a working and effective blend going forward between local, regional and national. The North stood up together and said, in practical terms, we have some maturity in this context. We have pockets of excellence. We'd like to see those pockets of excellence scaled. We'd like the learning from Helm and the Leeds personal health record to be understood somewhere else. We'd like the insight from how LPRES is architected to be available. We'd like to know what GNCR have done around their information governance. And that's already going on and will continue to flourish, I think, going forward. And therefore, collectively, the steps that are made in this community and the steps that are made across the North together will give us a better outcome and a better end picture. There was a French theme at the start. I don't know if anybody picked it up, but I definitely heard Amanda promise us, if we stuck with it today, that we, as in Marie Antoinette, there would be a let them eat cake moment at some point at the end. I was up in Newcastle on Tuesday with the Academic Health Science Network. For the art fans and critics in the room, this is a picture called Bathers at Asnières by Seurat. He was a post-impressionist. The really interesting thing about Seurat's work, or a pointillist, is that there is no picture there except that he has fastidiously gone and put dot upon dot upon dot upon dot. You can only see that because it's made up of the availability of the information in each one of those dots assembled up to give you an absolutely comprehensive picture. And that is ultimately where we are going when it comes to local health and share records, insight, personalised medicine. You cannot get there until you get all of those dots. There is no picture to see without the commitment to get all of the relevant dots on that canvas. Thank you.
So when I looked at that, it talks about pound plus, I thought, have they got sun cream on? So I don't know if anybody's got any questions they'd like to ask.
Hello, William.
We haven't primed him.
So, William Lamb, Integration Patient Flow CCO, but Bay Health and Care Partners, Morecambe Bay. Great North Care Act, or GNCR, their information sharing platform, they borrowed it, locked up and barreled.
I did, I absolutely walked into that one. Thank you, William. And I think the talent of anybody in the NHS who's clever enough to copy and adopt will be one of those ones that should be first on the list on James's framework for leadership going forward. Because the amount of time, effort and energy we spend doing something different than everybody else just for the bloody sake of it is embarrassing. So.
Oh, come on. We will have to move on.
So a question to reflect and to not to oversell digital. Okay, in Nature, the last publication of Nature, there was a very good editorial about not getting too excited about the potential of individualised cancer care. You know, we hear about genome processing, it's going to be the answer to everything. There's very little evidence, there's clear pockets of evidence, there's lots of expense around it, and one of the risks of digital platforms, you may generate use that doesn't have benefit, or you may be spending money on things that don't have benefit. And I see that our first challenge is to use electronic platforms to allow us to do and make sure we're doing what we're supposed to do better, to improve standardisation and to ensure that we're doing what we should do and to measure that. And that will have a huge benefit for us. But the other thing is to ensure that we're doing things sensibly and, rather than focusing on, you had your conversation about recurring cancer. We know that there's good evidence if you have sensible conversations about end of life and palliative care at an early stage, you will reduce spending in the last 12 months of life without reducing mortality. And there are some very difficult and sensible questions that we need to have utilising the platforms we're putting in and the sharing of end-of-life care pathways, but without getting too oversold on the, wearables, this, that, patient activation. Let's just do the simple things better with digital and then sensibly cherry-pick the things that are evidence-based moving forward.
So I think you're channeling Simon Eccles for about 95% of that. He's been very, sorry, the National CCIO, for anybody who don't know who Simon is, saying exactly that. Let's get the basics right. I think Amanda will go for your throat if I heard you right. You were making the sort of the notion that some of these things were frippery and wearables might be. And I did the same thing digital activation of patients was too. Not sure I agree. I think there's a real opportunity and potential there.
And you've ruined the next speaker's slot.
And as I said at the start, I'm not the doctor that's any use for you if you actually do keel over, but I could drag the PhD out and we could have a conversation about culture and end-of-life care and all of that, because I think you're absolutely right. I mean, mature conversations with people about that. I'm not sure they'll be enabled by digital, but digital might give us a bit more time and a bit more space for the passionate and compassionate conversations we need in those contexts.
Paul's got history as well around this, so he's one of his previous roles done a lot in telehealth and telemedicine.
Did?
Indeed. So thank you very much, Paul.
Okay, thank you.
Thank you.